Disclaimer, welcome to Triage RN. This podcast is for general education, entertainment, and discussion purposes only. All patients and scenarios are fictional, hypothetical, and generated using artificial intelligence. No real patient information is used. This podcast is not medical, nursing, clinical, legal, regulatory, employment, or personal advice, and it does not establish a standard of care or create a professional relationship. Do not use this content to diagnose, treat, triage, or make clinical, legal, or personal decisions. Always follow your local laws, professional standards, employee policies, and current clinical guidelines. Consult your own healthcare provider, lawyer, licensing body, employer, or professional liability insurer when appropriate. In an emergency, contact your local emergency services.
Red, yellow, green, where do you go? Time is longer than you know. Step by step through the double doors, we decide what matters more. This is Triage RN.
Hello. I am Anthony. I am your host. This is Triage R, and welcome back. This is episode number 4 now. We are cruising right along. We are. Now, we're going to get into this one pretty quickly because, as I said last episode, there's a lot to unfold on this one. I'm going into this completely blind, okay? I don't know what this triage is going to be, and I'm going to kind of try to break it down for you, and we're going to put a little twist on it. So bear with us. Now, just briefly, last episode, I had a little bit of feedback now, and I kind of heard it myself too, which is really annoying, but a little bit of mic touching, which we're going to avoid for this episode, which we got a nice new stand for, so I can't be touching the microphone because, you know, we don't like poor audio, so here we are. But we're learning. This is a process. We're here to learn. We're going to push forward. We're going to persevere, and we're going to get better. We're going to get better, and that's what this is all about, right? So I appreciate the feedback. We're going to push right along here now today because there's a lot to unfold. And I think this scenario in particular, or whatever scenario comes up, it's just going to be a lot because I'm going to do a little bit of reenacting on this side. We're going to chat about it a little bit on this side. And again, I don't know the subject yet. I don't know what the subject is. It could be something simple. It could be something not simple. But we're going to talk about it and kind of go from there. So all said and do, I basically am going to put into the AI generator here as to generate me a random triage. Create me a random triage from a nurse in a hospital, and let's see what it generates for us. All right, there we go. Give that a couple seconds, generate, and we're gonna pump this out right away. This is probably one of this one's a good one, actually. This one's a really good one. All right, let me just read a little bit about the story here. Let me make sure I got all the perspectives here, making sure we get an accurate demographic. Yep. I got this. Okay. And we're good. All right. All right. Okay. I got a good idea. Here we go. This is what we're going to do. We're going to create this triage, but I'm going to sit here as the triage nurse. I'm then going to sit there as the patient, and we're going to kind of reenact this triage the best I can. So bear with me. We're going to do our best here today. So, I'll give you a little bit of background about this patient before the patient kind of comes in, so you know a little bit about them, and then we'll go from there. Okay, so we have, does it say an age? I'm looking for an age. There we are. There we go. We have, and we're going to make this broad, okay? We're going to make this very broad, so there's no stipulation as to this is definitely not a patient. This is AI generated, okay? We have a 65 to 75 year old male who came into the emergency department. We're gonna call them I don't know, Ryan. Let's call them Ryan because I just looked at my Pokemon board again. So here we go. So we're gonna call them Ryan. They are a 65 to 75 year old gentleman who came in. Now this person, background history is quite healthy, actually. They have a little bit of hypertension. They do not have diabetes, but they do have some asthma. And other than that, they're not on many pills. They're on a cholesterol pill, it looks like. They're also on a antihypertensive. But that's it. Otherwise, this is a generally healthy year-old male, 65 to 75 years old. And we're going to get right into it. You don't know much else. This person walks in through the triage door right now. There's no one in front of you, so you're going to take this person next, and we're going to discuss it here right now. All right? So here we go. Hey, Ryan, come on in. I'm Anthony. I'm one of the nurses here. You want to have a seat and tell me what's going on today? Hi there, Anthony. This is, I'm Ryan, and Ryan. Is that my name? Yeah, I'm Ryan. How, what was your question? Why am I here? Where am I? It's really cold in here. Oh, can you turn the heat up, please? I just don't know. I don't know why am I here? Where am I? Hey Ryan, you're in the emergency department right now. Do you have someone with you here today that can kind of try to help us out, or how about we just hook you up to these vitals really quick and see what's going on a little bit further? Yeah, I mean, do whatever you got to do. I'm gonna be honest with you. I don't remember how I got here. Everything's kind of it's a blur today. I don't know. Oh my God, it's so cold in here. Hey Ryan, that's okay. Let's just get you hooked up to these vitals and let's see what's going on with you here today, okay? Do you remember anything about this morning? Do you remember what you had for breakfast? Tell me anything you can really remember, okay? As I'm doing that, the vitals are going to be as the following. Vitals are going to read off as a temperature of 39.2. Heart rate is 124 beats per minute. Respiratory rate is 28. We have a blood pressure of 92 systolic over 58 diastolic. We have an oxygen saturation of 93% on room air. And as you can kind of tell, he's kind of confused, doesn't really know what's going on. I just feel so crappy. All I can remember was, I don't even remember what I had for breakfast. I think yesterday I remember playing with the kids after daycare. And I don't know. All I know is I had to look after the kids after daycare because my son couldn't pick them up from the daycare, and it's just, I don't know what's going on. I just don't know. So at this point, I'm looking at Ryan and basically determining that, there's something going on with his vitals for sure. He's definitely a little bit confused. His overall demeanor is that he's shivering, probably because he has a temperature. He doesn't really remember the history of today, which is definitely concerning for sure. I want to investigate that a little bit more. However, I also don't want to spend too much time caught up on the story here because overall he does not look well, especially for his age category here. So I am a little bit concerned about this gentleman who is 65 to 75 years old. It doesn't have really any history that I can see here on the computer other than his cholesterol meds and his antihypertensive that he takes. His vitals are not great. They're not the worst, but not great. And I'm going to try to move forward. So in my triage here, I'm going to basically say that this gentleman presents to the emergency department. I'm going to say altered, confused, maybe. He's having a conversation with me, but he's definitely a little bit confused. Doesn't remember the better parts of today, or even some of yesterday, maybe. So he's a little bit altered. His respiratory rate is a little bit heavy, 28, so he's breathing a little bit hard. I'm going to put that in my triage. Overall, when I look at these, I'm going to say that he is septic positive. He is SIRS positive and septic positive. And we're going to talk about that in a little bit here as well. Now, the only thing that I want to investigate a little bit further is maybe some kind of source of infection with this guy. So I'm going to go over here and ask Ryan and be like, hey, Ryan, What brings you? Do you remember like hurting yourself? Do you remember having a cut on yourself? Do you have a cough? Are you throwing up anything? Any of those investigations to try to break down any kind of source here, just quickly in triage to figure out what's going on with this guy. I don't know, man. I just don't know. I don't know what's going on. I just don't feel well. And you know what? I remember. Yesterday I was playing with the kids, and I remember that I hit my leg on the fence, and I think it cut it somewhere back here. I just, my leg hurts. My leg hurts. Oh, my leg. Now, in this case scenario, I'm going to investigate Ryan a little bit further. I'm going to look into his sore leg. I'm going to listen to his lungs a little bit and determine kind of my source here of infection that might be happening. I do end up looking at his leg briefly, and I do discover he does have a gnarly little cut. I'd say probably a 7-centimeter laceration to his bottom of his calf area. It is swollen. It is red. It is flaming hot. His leg is probably almost double the size on his calf. And that was hard to tell because he came in with pants, right? So I did not see that originally when he came in. He seems to be walking on it okay from the most part. Doesn't really have too much of a limp, but if I really look, I can probably tell that he has a limp now. But his gait is relatively okay. But this laceration on his leg is definitely looking infected. It has some purulent drainage with some serosang drain as well. And it just looks bad, to be honest with you. It's red, it's inflamed. All those telltale signs that there is some kind of infection that brewed pretty quickly with this gentleman. Now, I would want to confirm maybe when he was playing with his children where he's not really fully with it right now. Maybe this happened like last week and he's getting, he just forgot or whatever. The timeline might be a little bit off here. But regardless, we're going to treat him the same as we normally would in this kind of patient. So right now in my triage, I'm basically going to put him... actually, we'll do the triage here live again here. All right, I'm going to put down Ryan in my CTAS as a skin complaint. I'm going to probably put it as a laceration to his lower extremity. Sutures, it does look quite controlled. There's no bleeding or active bleeding. He may need some sutures. I'm going to put probably may need some sutures because it is quite a large lac. Respiratory, 26. He's breathing pretty hard, to be honest with you. Moderate to severe. I don't think he's like very severe, but he's definitely moderately breathing. Circulatory wise, he's tachy. He's a little hypotensive. He's febrile. So I am also going to put, it is a positive shock index, right? So his positive shock index is above 1. So I'm going to put him in it as a shock index of greater than 1. However, he's not to the point where he's like, now, there's a great debate here, right? So, shock index greater than 1, he probably should be a level 1 CTAS. However, this guy's maintaining okay. He's not severely in organ failure just as yet. I don't think he's in septic shock as in yet, as he still has quite an okay blood pressure. 95 systolic, I think it was. So, we still have a little bit of time here, but he's definitely needs that urgent care right away for sure. So, he does have circulatory compromise, so I'm going to use that. He's altered. He's altered, but not. He can make full sentences. He can talk with me. So I'm going to put a little bit altered. Febrile. He's definitely febrile for sure, 100%. So my other modifier for this is that, he's hemodynamically compromised. He is going to be a level 2 based on his laceration of his skin, and we need to get this guy to see a doctor pretty quickly. And so I'm probably going to leave Ryan right in the chair, to be honest with you. I'll go talk to my charge nurse or Flo or whoever decides where these people go. And I'm going to determine and advocate for this person and just say, hey, this person is septic, and we're going to talk about that. This guy is septic. I'm concerned of his mental status. He needs some blood work and some care pretty urgently based on the signs I've found in triage. I'm probably also going to do an ECG here in triage before I go indicate to the charge nurse, or maybe after, if I have a couple minutes. I'm going to do an ECG on this guy right away, or I'm going to ask someone to do an ECG on this guy right away and get a line started and go from there. Now, as we break down this triage, okay, I have my vitals in there. I'm going to check a glucose in triage as well. I'm going to check his pupils. I'm going to listen to his lungs. I'm going to do an ECG on this guy. I have to do a lot for this patient because I have to kind of determine like why he's here and why he's having these episodes in triage, but I don't want to get too involved either, right? I don't want to go down this rabbit hole to be able to like treat him right in triage and create the longest triage of life. I want to try to keep to my 5 minutes, maybe a little bit more for this patient because he needs a little bit more attention. Probably keep it to like 7 minutes or under is kind of probably my goal here in this case. Now, Ryan gets back, he gets his treatment and does all that stuff, right? Now, I want to go back and I'm going to create the foundation here for you, okay? Things I want to talk about are sepsis. Sepsis is going to be the big kicker in this guy. And sepsis is, I love a good septic patient. Now, it kind of sucks, to be quite honest with you, because these patients require a lot of work up front. And then they kind of plateau with the interventions that they need for a little bit until the physician sees them, right? So let's talk about sepsis. Sepsis is so crucial. I cannot emphasize that enough. Sepsis has an extremely high mortality rate if untreated. The sooner you treat this patient, the higher the results and the less chance of death. And I'm going to say the word death, and I think everyone kind of jumps out of their seat and says, and we start to panic, right? But this is the emergency department, right? These types of patients have a high mortality rate if they're not given the right treatment. So we need to err on the side of caution, right? We need to do everything we can for this patient. So let's break it down a little bit, okay? We're going to break it down. So, sepsis. Sepsis has 4 different categories or levels of being septic, okay? And the best way I remember it is, well, the thing is, everyone talks about SIRS, right? Systemic Inflammatory Response Syndrome. SIRS is an early marker for anyone healthcare related that says, you know what? Something's going on with this patient. That doesn't mean they're septic, okay? I'm going to repeat. SIRS does not mean you are septic. I cannot make that more clear. I find, even myself, first starting out, I got that very confused for a long time, okay? SIRS is not sepsis. It is 2 different things entirely. Now, they go on the same scale with increments of increased severity. However, SIRS is not sepsis. Okay, I just want to make that very clear to everyone. Now, SIRS is your first level of indication something's going wrong. And I need to do a little bit more investigation to that. So SIRS, here is my criteria for SIRS, right? So SIRS, you could have a fever. So anything over or under your normal for your standards of your hospital. And I'm not going to throw out too many numbers here because I find these numbers can vary based on hospital to hospital to hospital or your region or those kind of things. Now, typically a fever is someone who is febrile above 38 is typically that window. I've seen lower into the high 37s as well. So check with your hospital, check with your policies, check with those people. Now, there is also an under indicator here as well, okay? And I think people forget about that, right? The under They are febrile if they are under. They are hypothermic, okay? That is an indicator as well for SIRS. So just remember that. And I'm not going to throw out a number because it's different everywhere that I've been. So please check what you think is at your region. So febrile, higher or lower, hyper or hypothermic. Tachycardia. So typically in someone who is SIRS positive, thresholds I've seen is somewhere around 90 beats a minute, 100 beats a minute. Again, it's different in different regions, so I don't want to get too focused on the numbers. But however, someone who is tachycardic based on your standard policies where you are, and for my instance, I'm going to go above 90 because that's what I was trained as a critical care nurse. So anything above 90 is going to be tachycardic for this person. Respiratory rate above 20. That's kind of like standard everywhere that I've seen is 20. So respiratory rate above 20. Blood pressure. Blood pressure is not part of SIRS. I'm going to make that clear again. Blood pressure is not part of SIRS. We're going to see that later on with septic when we talk about this, but blood pressure is not SIRS. Put that way back in the noggin and hold that for later. So that is not part of SIRS. Now, altered level of consciousness. That is part of SIRS. Okay? And I think that's the one we forget about quite a bit. Is the altered level of consciousness, all right? Now, there's different markers for SIRS based on places you've been as well, and there's new publications coming out of this as well. So again, check with your region, check with your hospital. However, I've seen someone put on SIRS white count before, SpO2 before, all those kind of things. And again, it varies from region to region, so definitely check. However, in this case, I'm going to include altered level of confusion. However, this person really doesn't need it because they have so many different things going for them. Ryan is just definitely sick all around, and I don't need to like adjust any of those or kind of go looking for any markers because he's SIRS positive right from the get-go when I look at this guy and do a couple set of vitals. So you need 2 of the 5 markers here, okay? The markers being febrile, tachycardia, respiratory rate, SpO2, and altered level of consciousness. That is 5. Those are your 5 markers, right? If you have 2 of the 5 of those that are abnormal, you are SIRS positive. Okay? SIRS positive could be 2 of any one of those. Now, if I come in and I'm a 34-year-old male or female, does not matter, and I have the flu, and I come in and I can make my heart rate go pretty high doing that, and my respiratory rate's high. Those are 2 markers right off the rip, and that indicates SIRS positive. Does that tell me someone is septic? No, it does not. That just means that they have something going on. They could be SIRS positive and something completely else be happening to them. So again, SIRS positive is not sepsis in any way, shape, or form. Okay, those are 2 different things, but they kind of fall together on the same scale. Okay, so that's SIRS. SIRS is kind of level 1, and we'll put level 1 way over here. So level 1 being SIRS. Level 2, and I think this is where a lot of people get very confused, is the between 1 and 2. 2 being septic. To be septic, you need a whole bunch of other criteria. Okay? So, in the case of Ryan here, he has a source of infection. So, for sepsis, you need to have SIRS positive. That's step 1 for SIRS. Step 1, okay? Step 2 that you need to confirm that you for sepsis is that you need to have a source of infection. And I'm going to say, to be more specific, you need a susceptible source of infection. You need to suspect that there's a source somewhere, and you need to have a good idea as to where it's at. Okay? So maybe you do a urine dip on this person, and that's your source. Or maybe you had an x-ray done on your chest the other day, and that's your source of infection. Or in the case of Ryan here, you have a laceration to his leg, and that could be my source of infection. So with Ryan in particular, he has that massive lac, and it looks like it's a little bit older, right? Like, I don't actually think it probably happened yesterday based on his story, because he's a little bit kind of not really with us here today. He's a little bit confused. So his source of infection could have happened the other day, could have happened 2 days ago, 3 days ago, a week ago, who knows, right? But in this case, it doesn't really matter, because that is what I'm going to treat as his source of infection. So that is step 2 to sepsis, okay? So step 1 again is going to be your SIRS positive. Step 2 is going to be a suspected source of infection. Level 3. Now, again, before I start step 3, I could come in. I'm a 20-year-old person who comes into the emergency department. I could be SIRS positive and have a source of infection, because my source, maybe I'm hacking up a lung and I had an x-ray yesterday, or I'm hacking up a lung and that's my source because I'm spitting up a whole bunch of green stuff, right? That doesn't mean I need to be treated faster or right away. Okay, that doesn't mean I'm septic yet. It just means that, you know, maybe you're along the journey, but that doesn't qualify you as being septic yet. Okay, so you have a source. You need one other step to classify someone as being septic. That one other step is the following, and that could be your age modifier. So these are all going to be modifiers, right? The modifiers are going to be someone who is over 65, someone who has recent surgery, someone who is immunocompromised, someone who has chronic illness is number 4. So major chronic illness, that puts you at a higher rate. And the last one I think people get confused about is looks unwell. So maybe someone comes in who's 50 years old, who has the same story as Ryan. However, maybe their vitals are a little bit better, but still kind of meets SIRS positive. They have that suspected source of infection, and they have none of the modifiers, but they just look terrible. They look like they're diaphoretic. They look flushed. They look pale. Any of those things, they just look unwell. And that is up to your discretion, right? This is probably not your 34-year-old that has the flu and is just going through a hard time and they just feel shitty. This is someone who really just looks unwell. Now, this is very up for debate by person to person, whoever's doing the triage. However, use your clinical judgment here, okay? If you look unwell, treat it as unwell, okay? And I think that's where people get confused as what's unwell, what's not unwell, and they want a line in the sand as to what is what. You're not going to get that, right? You have to use your clinical judgment, your experience with these type of patients to say, you know what, Ryan, you look unwell. I'm going to put you in this category and we should start some treatment on you sooner than later. Okay. So to recap, for sepsis, okay, to classify someone as being septic, you need 2 of the SIRS markers, okay? This is level 1, okay? You need 2 of the SIRS markers. So you need your heart rate, respiratory rate, temperature under or over, altered level of consciousness, and some people use O2 as a modifier. If you require an oxygen, not require an oxygen, SATs below 90. Again, check with your facility. It's different everywhere. Those are your markers for SIRS. Level 2 to sepsis, you need to have SIRS positive, so 2 of those. Level 2, you need to have a source of infection or a suspected source of infection, which we do have here with Ryan on his leg. And then level 3, you need all 3 of these levels to be septic, okay? You need to only have one of these modifiers. You need to look unwell, over 65 years old, recent surgery, immunocompromised, or chronic illness. You need to have one of those. If you meet every level of that category, so if you have 2 of SIRS, you have a suspected source of infection, and you have 1 modifier of those 5, then you are septic. You need to have all of that together to be septic, okay? There's a lot to it. That is a lot to remember, okay? So sometimes you need to put a little reminder on the wall in triage. You need to put a little reminder on your desk or on your desktop, whatever you're using, to be like, let's fit this criterion. Let's check it off as we go, right? Now, the more experienced you get with these kind of things, the more easier it is to indicate. However, in the case of Ryan here today, he's over 65 already. He has that modifier. He has a source of infection, and he is SIRS positive. So boom, 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 boom. He's septic, right? Now, the kicker to this is that there are stages 3 and 4 of sepsis, right? So we have level 1 being SIRS, level 2 being septic, level 3 is severe sepsis, okay? Severe sepsis means I am hypotensive in this scenario. Ryan is kind of getting on the verge of hypotension, right? I think his blood pressure was like 92 systolic, if I remember correctly, and I'm going to pull that up here just to verify. Yeah, 92 systolic, right? So he's kind of getting there, but not quite there yet. I wouldn't really classify him as... Yeah, 92 or 58. I wouldn't really classify him as being hypotensive yet. Now, maybe he runs 95 systolic every day, and that's just how he lives his life. Now, if this person normally runs their life at 168 systolic, then maybe I'm going to classify this as hypotension, and maybe he's severe sepsis. Severe sepsis. And maybe that's where I need to draw the line in the sand, right? Again, use your clinical judgment. Use your sources and what you have in front of you, right? So if you have a database in front of you that logs all their vitals from recent visits and those kind of things, you can compare that right in triage, right? Maybe you can't, though. Maybe if you can't and you don't have that access, you're going to run it off of, hey, Ryan, like what do you normally run for a blood pressure? If they don't know, then you kind of have to use your clinical judgment, right? Now, some standards are going to say anything below 90 systolic, that's your threshold for being severe septic, right? So 90 or below is going to be hypotension. Anything 90 and above is not. So again, check with your facilities, check with your policies. It could be different everywhere else, but use your clinical judgment too, right? So if this person usually runs 168 systolic and now they're 92 systolic, that's a problem. Like that's more hypotensive, and I'd probably classify them more in the, severe sepsis category. So look into it. And don't just base it off one thing. Use your clinical judgment as well, right? So that is level 3. So we have, again, just to recap, because this gets quite confusing for people. Level 1, we have SIRS positive. Level 2, we have septic. Level 3, we have severe septic. That's including your hypotension right there in that third category. Fourth category, septic shock. Has a very high mortality rate. Needs to be taken very seriously, okay? Now, to be septic shock, there's only one real identifier you need to remember. You need to have all of the things we just discussed. SIRS positive, septic, severe septic, so hypotensive, and we need to have tried to have treated that severe sepsism. I don't know if severe sepsism is actually a word, so we're going to go severe septic on that. I'm going to rewind. We need to say that severe septic, you need to have tried to have treated, right? So I needed to try to give some fluids. These people typically need liters upon liters of fluids to treat their hypotension sometimes. So I need to try to get a couple liters, a liter, 2 liters, sometimes 3, sometimes 4 liters. It's going to be physician driven. This is usually not nurse driven, so just bear with me here. You need to have tried to give those fluids. The fluids are not working, okay? When the fluids are not working and they're still hypotensive, that is septic shock. That is septic shock, when the fluids do not work. In septic shock, the way we treat, we go to pressors, okay? We go to pressors. Pressors are agents, they're drugs that increase your blood pressure by squeezing those pipes, right? We're squeezing the pipes. Typically in the emergency department, norepi. is going to be your number one kind of go-to for pressor meds. Okay. Now it varies from facility to facility. Again, clinical outcomes say norepi is typically has a higher success rate. But I've seen things in different places too, based on maybe allergies, based on comorbidities and those kind of things. Norepi is typically your go-to. Now, I've seen norepi kind of mixed up the same way in each hospital, right? I think pretty much you put 4 in a 250 bag. I think I've pretty much seen that everywhere I've worked, but fact check me on that one if you do something different. If you're not putting 4 milligrams norepi into a 250 mil bag, that's typically the gold standard here. And then you're going to run a drip on this person, right? You're going to run a norepi drip to treat their septic shock. And that's when this person is definitely not in your triage room anymore. They're in your resuscitation room. They're in your trauma room. They're somewhere not beside me because they need urgent care right away. Now, thankfully, in this case, Ryan got the care he needed because I advocated for my patient. I went to go see the charge nurse, flow nurse, whoever it might be that make these decisions. I went to go see them. I got things started right away. Now, the last thing I really want to talk about in this case is, and I've seen it done in different facilities, right? So I want you guys to go back and advocate for this if you don't have it, okay? So in most hospitals I've worked at, nurses either have care directives or some kind of something that allows nurses to do something before they see the physician, right? Before they go see the doctor, I, as a nurse, can do certain things without a doctor's order, okay? These might be whatever you have at different facilities. Now, in this case, when someone is septic, the quicker you get the treatment, the better. The gold standard here is from entry of door of triage, this person should get antibiotics within an hour. Now, they're looking at this and saying an hour might even be too long. We may have to drop this to a half hour. I don't know if with our volumes and amount of people, I don't know how that would work, but currently I find that an hour is quite quick as well. So these people, as soon as they walk in, you determine they're septic, they need to get antibiotics within an hour, and that drops the mortality rate significantly, okay? So I advocate for you that now in the hospitals I've worked at, they've done a really good job, and they have these policies in place where you can go and start antibiotics as nurses. And I love this, right? I think you're really advocating for your patient for this. And let's say, I'll give you a breakdown. So for Ryan, right? Let's say his vitals were maybe about the same, maybe a little bit better though, maybe a little bit better, maybe the same. He has a source of infection. We don't have beds for Ryan right now. He's going to have to wait a couple minutes. Maybe he's not altered yet. Maybe he's, GCS 15. He remembers everything. And he can wait a little bit to try to get a bed until we clear up a bed for him or a chair or whatever that may be. In the meantime, as a nurse, we should be starting blood work on this person. We should be starting IV access on this person. We should be starting fluids if indicated on this person. Typically, if they're below 90 systolic, we start fluids right away as a bolus. If they're above 90, typically, maybe you start a little bit of a drip rate. Maybe it's not a full bolus, but you start some kind of fluids. And antibiotics. Antibiotics are going to be your lifesaver here, okay? Now, some facilities have it different everywhere I've worked. It depends on what category. Maybe you have to go check with a doctor to get the antibiotics, or maybe it's nurse-driven antibiotics. Maybe if I have an unknown source of infection, but I suspect it's something, I'm going to give Piptas, for example, right? So having these advanced care directives are life-saving to patients, and that's how we can advocate for our patient and really be there for them to help save their life. That's what we're here for, right? So Ryan comes in. I've determined he's a level 2 for his septic, for his laceration on his leg. Again, maybe he's not altered this time and he can wait a little bit. I'm going to say, hey, charge nurse, we need to get something started for this guy. And someone else comes over and they get a line started on them. Or maybe you have time in triage and you start a line on them and we start doing some blood work. Blood work usually, and don't quote me, it's different at every facility, but maybe you're doing a VBG, maybe you're doing routine blood work, CBC, creatinine, lights, glucose. The other thing, maybe we're doing, we're definitely doing this. We're definitely doing cultures, so blood cultures on this person. Typically, you do 2 sets on 2 different sites. So you're going to do aerobic and anaerobic on maybe the left side, and then maybe you're going to do anaerobic and aerobic on the right side. So at least 2 different sources. I think like ID, infectious diseases, is going to tell you may need 3 sources of infection, 3 different sources of blood cultures. So they're looking into that now. These people are a lot of work, right? But as long as you can early indicate sepsis, you can start interventions early. Blood work, you can do IV access, start some fluids, get those antibiotics into them within the hour. These people typically have a good outcome in the end. If we can early indicate sepsis, early interventions, they typically do really well, okay? And we need to err on the side of caution because, and I've said this a lot of times on this episode, that it has a high mortality rate if untreated quickly, okay? Especially when you get into that older population, the comorbid population, the immunocompromised population. They need that treatment right away. Do not hesitate. Get it done, people. Get it done. It is so important. I cannot express this enough, how important it is to really early indicate that sepsis, early interventions. And I feel like a broken jukebox right now, and I'm just saying the same thing over and over, but I just want to get it clear because it's so important that these people get their antibiotics soon within that hour window of being triaged. Now, because of you, Ryan got his treatment. He got in sooner. He got the medication he needed. He got the treatment he needed, and you advocated for your patient like you're supposed to do. And you know what? That's what we're here for, right? We're here to save lives. We're here to help advocate for our patients, and that's what being a nurse is. That is what the core nursing is all about. And I just want to say thank you. Thanks for tuning in for episode number 4. It's been wild. I really like the acting out the scenario too. So if you guys like this format, let me know. I appreciate your feedback. Thanks for tuning in. I'm Anthony. I'm your host. This is Triage RN. Over and out.
Red, yellow, green, where do you go? Time is longer than you know. Step by step through the double doors, we decide what matters more. This is Triage RN.
Podcast disclaimer. The Triage RN podcast is provided solely for general education, entertainment, and professional discussion purposes. All patients' names, personal details, medical history, symptoms, assessments, test results, treatments, outcomes, and clinical scenarios presented in this podcast are fictional, generated using artificial intelligence. All scenarios are hypothetical. No real patient, patient record, or professional health information is knowingly used or portrayed. Any resemblance to an actual person, patient, healthcare encounter, institution, or event is entirely coincidental. The information discussed on the podcast is general in nature and may be simplified, incomplete, outdated, inaccurate, or unsuitable for a particular situation. It does not represent a complete clinical assessment, an official guideline, an institutional policy, or the application standard of care. This podcast is for discussion purposes only. It is not medical advice, nursing advice, clinical advice, legal advice, regulatory advice, employment advice, or personal advice. Nothing stated, shown, suggested, or discussed during the podcast should be relied upon or used to diagnose, assess, triage, treat, or manage any medical condition, make emergency medical, nursing, clinical, legal, regulatory, employment, or personal, replace an individual, patient, assessment, or professional clinical judgment, determine a healthcare professional scope of practice, replace current legislation, clinical guidelines, professional standards, workplace policies, procedures, protocols, or medical directives, or establish a standard of care for any healthcare professional or organization. Listening to, viewing, downloading, commenting on, or otherwise interacting with the podcast does not create a nurse, patient, clinical, patient, healthcare provider, patient, lawyer, client, consultant, client, or other professional relationship. Listeners should independently verify all information and consult the appropriate qualified professional before acting on anything discussed. Healthcare professionals must follow the laws, professional standards, licensing agreements, scope of practice rules, clinical guidelines, employer policies, procedures, protocols, and medical directives that apply in their own jurisdiction and workplace. Questions concerning professional practice, licensing, employment, discipline, documentation, privacy, or legal liability should be directed to your own lawyer, professional licensing or regulatory body, employer, union, or professional association, and professional liability insurer as applicable. Anyone experiencing a medical emergency should immediately contact their local emergency services or attend the nearest appropriate emergency facility. Do not delay or disregard professional medical care based on anything heard or viewed on this podcast. The views and opinions expressed by host and guests are their own. They do not necessarily represent the views, policies, practices, or positions of any hospital, healthcare organization, employer, educational institution, licensing body, professional association, sponsor, or other affiliated organizations. References to medications, products, services, organizations, guidelines, or third-party resources are provided for discussion only and do not constitute approval, endorsement, recommendation, or sponsorship unless expressively stated. Although reasonable efforts may be made to provide reasonable and accurate information, no representation or warranty is made regarding the accuracy, completeness, reliability, usefulness, safety, or currentness of any content. To the fullest extent permitted by applicable law, the podcast creators, owners, hosts, guests, producers, sponsors, distributors, and affiliated parties disclaim responsibility and liability for any injury, harm, loss, damage, claim, cost, or consequence arising directly or indirectly from accessing, relying upon, interpreting, applying, or misusing any podcast content. Use of this podcast and its content is entirely on the listener's own risk. Nothing in this disclaimer is intended to exclude or limit any responsibility or liability that cannot legally be excluded or limited under applicable law. Do not submit, post, email, or otherwise share identifiable patient information, confidential workplace information, or personal health information with the podcast or through its associated social media accounts.